everybody. Really nice to see some very familiar faces and some very familiar names on the screen. My name is Rachel Hollis and I'm chair of the Royal College of Nursing Professional Nursing Committee. So it's a great privilege to be here this evening and to have been invited to chair this event to celebrate International Nurses Day. So the first thing I have to do, of course, is to wish everybody, and particularly those nurses in the room, a very happy International Nurses Day. And it's brilliant that everyone is here today to celebrate the event and to hear from our keynote speaker, Lord Nigel Crisp, who's going to be talking to us about nursing now. But first, I have a number of apologies that I need to give and a few housekeeping notes that I will pass on to you. So first of all, to say that we've had a number of apologies, including the Right Honourable Sir Simon Hughes, Chancellor of South Bank University, who asked us specifically to wish everyone a happy International Nurses Day from him and to say hello to Lord Crisp specifically. We have apologies from Jill Iliff from the Commonwealth Nurses and Midwives Federation. She's currently in Australia. From the Honourable Joseph Garcia, Deputy First Minister of Gibraltar. From Lord Monroe Palmer, the Deputy Speaker of the House of Lords. Daisy Cooper MP, Deputy Leader of the Liberal Democrats. Annette Kennedy, the President of the International Council of Nurses, and also Howard Catton, the CEO of the ICN, both send apologies, as does Judith Hunter, former chair of RCN Council, who I understand is actually running a COVID-19 vaccination clinic this evening, so can't be here, but sent her apologies. But it's certainly good to see other former chairs of council, so nice to see Sue Warner with us, and former presidents, and particularly always lovely to see Cecilia Amin, so welcome, sis. So great to have so many people here. Just asking people to keep on mute so we don't get feedback, and you will have been muted as you arrived. There will be an opportunity for questions later, and when those questions come, then I'll ask people to unmute. If you do have questions for Lord Crisp as we go through the evening, then what I'd ask you to do is to put that in the chat, but address it to me specifically. So that's to Rachel Hollis rather than to everyone, unless it's just a general comment that you wish to make to everyone. And of course, then use the general chat. The meeting this evening is being recorded, so I hope that that's okay with everyone. And obviously people are free to put off cameras if they wish to do that, but hopefully you'll keep your cameras on so that we can see you. The order of events is that Lord Nigel Crisp will speak first. We'll then have a short discussion with any particular points from Lord Crisp's talk, and then there will be the opportunity, as I say, for people to ask questions. And if you put in the chat to me any questions that you have, and I'll then ask you to unmute and to give your question. And what I would ask is if people can be fairly short and concise in their questions, and this is perhaps particularly to June, if we can just have one question rather than having 3 questions, which I know, June, is usually your practice. So, but if we could have one fairly short question, and then that gives us time for everyone. As we draw to a close, then I'll be asking Timothy Jackson, a nurse, a midwife, and a member of the National Liberal Clubs, to make some concluding remarks and give the vote of thanks, so that the meeting will then close at 8:15. So without further ado, it's my great pleasure to welcome our keynote speaker, Lord Nigel Crisp, who I think will be known to many of you in the room. And Lord Crisp is former Chief Executive of the National Health Service in England and Permanent Secretary of the UK Department of Health. He co-chairs the All-Party Parliamentary Group on Global Health, which published the Triple Impact report on nursing back in 2016, which was one of the catalysts for the Nursing Now campaign, launched in 2018 and now drawing towards its end. Nursing Now has been co-chaired by Lord Crisp, and of course we'll be hearing more about all that this evening. So it gives me great pleasure to hand over to Lord Crisp to speak on nursing now and in the future. Lord Crisp.
Well, thank you very much indeed, Rachel, and please call me Nigel. I find the title is useful to get you in the room, but once you're in the room, let's use first names, shall we? Otherwise, I'm going to have to call you probably Dr. Hollis. Shall I start by sharing my screen? Let's see if I can do that. Good, and from the beginning. Good, succeeded. Right, well, firstly, thank you for inviting me, and what a privilege, particularly as a non-nurse, to be talking to you this evening on the International Day of Nursing, or Nurses. International Nurses Day, I think I probably got it in the right order now. Let me add my congratulations and best wishes to all the nurses in the room and beyond. And let me actually start with a tribute. And the tribute is really about COVID, because we do know that everyone who's working as health workers, as nurses, but also as others around the world, have been having a very tough time for a year or more. And all of us who aren't working in that owe people an enormous amount, a great deal. And nursing, I think, has come through this year spectacularly well. We've seen it with the increase in recruitment into nurse training here in the UK, but it's true everywhere that nurses have been everywhere, from in the community and counselling people right the way through the system to the most acute areas in intensive care. And my colleagues in the NHS tell me that the two groups who have come out with most prestige out of this are nurses and intensivists, with the two groups that I hear people saying to me, and I see you nodding on that, Rachel. So I and everyone owe people, and nurses in particular, a great deal for this last year, and I know how tired people are getting, of course. Now, I co-chair the All-Party Parliamentary Group on Global Health, and we did this review, which Rachel mentioned, called Triple Impact, which really said 2 or 3 things. It was the first review, actually not many reviews of nursing globally have been done, and we used the Commonwealth to talk with a lot of people around the world about nursing, and we came up with some very common themes that nurses will recognise. Firstly, we're simply not going to achieve health for all, universal health coverage throughout the world without strengthening nursing. And secondly, nurses are too often undervalued and underutilised, in the sense, not that they're not working hard, but underutilised in the sense of not being able to work to what the Americans would call the top of their licence. People are trained, but they're not able to work for regulation or for cultural reasons or whatever. And that is the most extraordinary waste of talent and passion, and of course resource within the whole health system everywhere. And I in particular came away from that report very much convinced that one of the biggest things we could do to improve health globally was to strengthen and develop nursing globally. And I'm going to say obviously a bit more about that. And that's really why we started the campaign. It started from the All-Party Parliamentary Group. And it was really Mary Watkins and I, many of you will know Mary Watkins, Baroness Mary Watkins, who is a nurse, mental health nurse, talking in the Peers guest room in the House of Lords. And, you know, we'd written this report, which got well received in the nursing world, but actually nobody else was interested. So frankly, we got fed up, or words to that effect that are probably ruder, and decided, well, why don't we do something about it? So I actually wrote to a number of friends around the world, all doctors as it happens, doctors in Mexico, in the US, in Africa, in India and China, and said, what do you think? Do you think we should have a campaign like this? And all of them came back and said, yes, you know, now's absolutely the right time. And it was interesting, that came from doctors, senior doctors around the world. So we started to put the whole thing together, create a 3-year global campaign to improve health. So it was focused on health by raising the profile and the status of nursing. And we had a few objectives about investment and so on within it. But it was, you know, it was vision-led, not plan-led, and that's a really important point. We didn't have particular goals. We were actually trying to make a step change, recognizing that the change we want to see will take a generation. So moving on from there, it just took off. We had got, this is just 4 examples of people launching it around the world. That's Malaysia. I think one of these is Spain. The bottom left-hand corner is, that's actually either Qatar, it's Qatar actually, looking at it, and Germany, I think. And it just took off around the world. And it's interesting, we set this up as a global campaign. You may not have heard about it in the UK because we were deliberately not UK focused. I've done only 1 or 2 of these presentations in the UK in the 3 years of the campaign, deliberately. So this wasn't a UK, or not selling UK nursing or a UK model of nursing or anything like that. And actually the biggest needs, of course, as you'll all well understand, are in Africa and elsewhere in the world. We very fortunately were able to get the ICN, the International Council of Nurses, and the WHO, the World Health Organization, alongside us to be our supporters and our colleagues and our associates. And we set up a board which has actually 21 people on it, 16 nationalities. We were very deliberately had it as 2/3 nurses and 1/3 non-nurses, 2/3 women and 1/3 men, and 2 young nurses, by which we meant under 35. I'm sure we're all young, but anyway, we took the under 35 as being the basis for it. So we tried to make it broadly representative, but actually we got our credibility from being linked to WHO and ICN. That was our legitimacy, if I can put it like that. Otherwise, we were just a ginger group who'd got ourselves together and were trying to make something happen. So we set off, and I co-chair it. It was decided I would co-chair it with a woman called Sheila Clow, Professor of Nursing, more importantly perhaps, former Minister of Health in Botswana, and indeed presidential candidate in Botswana. She informed me the other day. Great woman. So we had an African and a European, we had a woman and a man, we had a nurse and a non-nurse, and actually we had an extrovert. You should meet Sheila and me, who's an introvert. So we had a terrific, wonderful opportunity for me to be working with her. And then we had these launches around the world. First one was Uganda, which was very shortly after we launched in 2018. And the last was actually Saudi Arabia, would you believe? And that was in January this year. And you can see it's a massive global movement. There are actually 800 now, regional, national and local groups, and 126 countries, all self-funding. We didn't have any money, and we didn't give them any money. They all, if they wanted to be part of this, they had to get their own resources together in whatever way. But the last 3 countries to join, really interesting, were China, Russia and Saudi Arabia. And the big starting point was in Africa, and then it spread from there around the world. So let me carry on. We actually had a number of wins. When I judge the success of this, I judge it in terms of what happened locally in nations. We only had 5 members of staff. We weren't going to make a big impact in countries, but it's what people did locally that mattered. But there were 3 things that we managed to do globally. With others, we managed to get the ICN to appoint a chief nursing officer with that title. First time ever. There'd been senior nurses there before, but nobody right at the top of the organization reporting to the DG. We got this was our idea, and we got the 2020 as the International Year of the Nurse and the Midwife with WHO support, which was terrific. Didn't work out. It turned out to be the year of COVID as well, didn't it? But nevertheless, we had a lot of things happening and a lot of leverage and interest as a result of that. We also got this was the other thing we persuaded the WHO to do, is to publish the world's first ever State of the World Nursing Report. And it really provides for the first time the data of what's going on in different countries around the world. It's not perfect, but it's pretty good, and it'll be continued in 2 years' time with an update and so on. And that means it's now on the WHO agenda, and this year they're debating the strategic directions for nursing and midwifery. So it's been staying on a high level in the WHO agenda, and that's what we could do globally. We could shift the global agenda, but we couldn't shift the national agenda. And it's all those local groups who are doing what they're doing in their countries, including countries like, I mean, I just pick out Pakistan for no particular reason other than they had a fantastic launch where the government committed $171 million actually to expanding nursing and from the president of the country, and other examples, Mexico, Uganda, and so on, where there's been real impact that people have made a change there. But that's their story, not mine. Now, it comes to an end. We come to the end with 2 events next week, one on the 18th when we publish our final end of term report, and then one the following week on the 24th when we have a final conference that goes around the world, starts in Australia and follows the sun and ends up in the other side of the world in the United States. And we hope that these events will be online, and you're very welcome to join them should you wish, and to get a copy of our end of term report. It's not the end though. We have tried to make a step change, but the work will be carried on in 2 particular ways. One of them is with ICN picking up the links with all the with all the Nursing Now groups, but also with this, which is the Nightingale Challenge. We actually set out a challenge. This is how to do things without money. We challenged employers around the world that last year they should provide development opportunities for young nurses and midwives at their expense, and doing it according to the agenda that they saw was important, non-clinical opportunities around leadership and understanding systems. And as a result of that, we were aiming for 20,000 young nurses and midwives involved. We had 32,000 in the end involved. And actually the Burdett Trust for Nursing, which nurses in the room will know about, have decided to continue this, and it's going to be known as the Nursing Now Challenge. So we'll be really building the most fantastic network of young nurses, 35 and under around the world, who I think are going to be a real voice for change for the future. So watch out for the Nursing Now Challenge and these strong and very effective young nurses. Now, I've been talking about why nursing is important, but I believe nursing is going to become even more important in the future. And there are some very straightforward reasons for that. The world is changing. Epidemiology is changing. Thinking about chronic diseases, long-term conditions, non-communicable diseases, whatever you want to call them, the diabetes of this world, the cancers and so on. We know that nurses have a particular ability to lead work in that area, and they're the natural people to be taking the lead in a whole range of services around long-term conditions, with of course other specialities and other disciplines bringing in their part from time to time. But that long-term care links very well with where nurses are coming from. Nurses of course have this biopsychosocial view of the world, a holistic view of the world, which is of course what we need increasingly in a world where we understand that health is not just about the physical, nor is it just about the mental, it's also about the conditions and the society we live in, and haven't we understood that during COVID? It's also about an increasing view around the world of the need for more value and for higher quality, and that again brings nurses more to the foreground. Interestingly, we couldn't have had this debate 30 years ago, but now we can, because there's a real track record and evidence of people like Rachel as specialist nurses, nurse practitioners and others. The evidence is out there now. It wasn't there even 15 years ago, perhaps. So now there's a track record to point to, and there's senior people who understand this and can move it on. Importantly, changing status of women as well. Our evidence was very much that how nurses were treated in the country was pretty much correlated with how women were treated in the country. You may not be surprised to know. And as that is changing, it's improving. But also COVID. And I think COVID has driven a higher profile and a greater appreciation of nurses in very many countries around the world. So what will that mean in the future? Well, it'll mean some of the stuff we've got in the UK, but I think we're going to see more nurse-led clinics in areas of non-communicable diseases, more specialist nurses and nurse practitioners, nurses taking a much bigger lead in primary and community services. I can imagine a situation even in this country, and it's certainly true in Africa and other countries, where primary care is going to become very much nurse-led, with medical staff, some medical staff in primary care, but the medical staff more grouped around the hospitals. And I suspect that is actually a sort of model that we will start to see happening in this country, and maybe in 20 years' time, we will see some really significant change there. But also finally, a final point I just want to make here, which is this one about public health and health creation. again, COVID has demonstrated very clearly to us that there is a great gap, isn't there, in our public health system, a great gap in health promotion and disease prevention, but also a great gap in what I call health creation. And I'm very happy to talk about that in the longer term. So I've probably hit about my right time, I hope, Rachel, in terms of just setting out the scene of what Nursing Now has been about over the last 3 and a little bit years, but also why I think this is just the beginning. I do think that in a few years' time, we're going to be, we lay people are going to understand much more about how important it is to develop nursing. And I come out of this campaign more convinced than I was at the beginning that one of the biggest things we can do to improve health globally is empower nurses. Develop, strengthen and empower nurses globally. Thank you very much. Thank you.
I can see lots of silent applause on the screen, Nigel, and I think that was and a few symbol applauses as well. So I think really helpful to set out the journey of Nursing Now and where it started and where it came from. And I guess just a question from me, sort of thinking of that 3-year journey, what's the thing that you're most proud of?
I think we're most proud of, I can think of people I'm really proud of and having given them the chance. Some of the young nurses, there's a young nurse from Zimbabwe who's turned into a real star. He was actually a student nurse when he joined us. He's not a student nurse now, and actually he's actually just leaving clinical work for a moment to come and do an MPH at the London School, actually, as it happens. So this is a young rural nurse from Zimbabwe. So I think there's examples like that of people where there's been a sort of impact. But I think probably some of the stuff around the World Health Organization, which is where people like me have had the opportunity to leverage it. It has shifted up the agenda at the WHO. You all know as nurses, those of you who are nurses, you're the only other business on other people's agenda, aren't you? That's too often where it is, and that has shifted. Now, you know, whether it will stay shifted, there'll be continuing pressure to do that. And the other thing I'm proud of course, is the Nightingale Challenge with those 32,000 young nurses, paid for by the employers. Absolutely.
No, I think that's a huge legacy, and I know the legacy of Nursing Now as it draws towards a close is important. I've got a few questions coming through, so I'm going to call people. So the first question was from Asha. Asha Day, would you like to ask your question?
Oh gosh, I've got to have a look at my question now. I think what I asked was, if I can remember, Rachel, it's about the potential of our public health colleagues. I'm a health visitor by background. Well, I'm chair of BINA, British Indian Nurses Association, and most of those nurses seem to be intensivists, so they come over and have their clinical expos. I'm the what I call the different nurse. So I talk about public health, I talk about the social determinants of health, I talk about reaching out into the community to engage with them, and we often call them hard to reach. They're hard to reach, they're just easy to ignore. So a term that I think it was 2004 that I coined, and I'm glad people have nicked it, stolen it and used it. But for me it's about, and COVID explains this. I mean, I had the wonderful opportunity to go out to India and work in North India with WHO, and I got very frustrated because they were saying, oh, we've got nothing like you in England, but if you want to go out to the villages, then you can actually go out with a midwife. And I'm thinking, no, but there's more to public health nursing than just midwifery. You're talking about a whole family approach or a whole village approach. And then I ended up in Alaska, and people say, why are you going to Alaska to do some work? And I'm thinking, because they have similar issues. They have issues of opioids and alcoholism, and they have the same issues as those communities are far slung and they don't trust people from the lower 49. So how do we develop and have a look at those nurses and their career paths, and also help them to have those other skills? And I remember talking to a fantastic consultant perinatal mental health psychiatrist called John Cox, and I worked with him, and he said to me, he said, Asha, I'd rather have you working with me around paternal and infant and maternal health rather than a psychiatric nurse is because you look at the wider thing. So you look at the whole gamut around holistic care, and you will look at housing, you will look at clean water, you will look at clothing, you can look at, you know, how much people have. And as a health visitor, you don't, yes, I'll have a cup of tea, even if it's in a jam jar, because I get a peek in what is in your fridge or what you eat, etc. And having taken an MP out, he was said, how do you realise? I said, because I asked her, and she asked me for a cup of tea, so I happened to say, well, I'll help you with it, and I'll have a look what food that you've got for the rest. But for me, it's about, that is the next wave, and how do we influence it? Because unless we get the health of those nations right at the very start in the public health field, we're not even get them into hospital.
Thank you, Asha. So the question is about sort of how we really prioritise public health, and I think Nigel, that was sort of towards the end of your presentation. And
yeah, shall I just pick up 3 very quick points in response to Asha?
That would be great.
I mean, firstly, one of the reasons why nurses are the first health worker that most people meet, actually globally. It may not necessarily be true in the UK, but it's certainly true globally. And generally a part of the community they serve. That actually gives them fantastic advantages with regard to public health. Secondly, there's a report coming out on Wednesday next week, on the 19th, from WISH, the World Innovation Summit on Health, which is led by, it's a report led by Michael Marmot, who people may know, but the social determinants, and a woman called Catherine Hanaway, who was the interim leader of the Nursing Now campaign for a while. And it's on nursing and social determinants together. And I haven't actually seen the recommendations, but I imagine it's practical. And it's certainly intended to be practical. So there's people moving in that direction. But let me take it even further than that, because of course prevention is important. In the UK, at last, we're really starting to take prevention as an important issue. But I want to be talking about health creation as well as, and the causes of health, and not just the causes of disease. And the nurses are also very good in this area. And I think of one who some of you will know, Heather Henry, up in Salford, just beside Manchester, or maybe Manchester's beside Salford, depending on where you come from, and who works with people in the community in terms of them changing the way they think about themselves. Really interesting. It's not just about changing lifestyle. It's actually, she says she's now in the business of injecting confidence, where before she was injecting medicines. Really interesting. So I think there's some big developments. I think you're right, actually. This is one of the big areas of development. It's not the only one, but it's one of the really big areas of development that you as nurses should be taking over.
Thank you, Nigel. And our next question is from someone who describes himself as an early career nurse. So Craig Davison. Craig, would you like to ask your question?
Yes, certainly. Thank you very much for inviting me along this evening. It was Trevor Peel that invited me, so thank you. And Asha, I loved your comment there, because I've just moved into a public health role and I'm doing a master's in public health, so I'm all about public health. So I started in an infectious disease ward, but I've recently moved to a nurse-led team, and we triage newly arrived asylum seekers into the UK, specifically in Glasgow where I work. So it is completely nurse-led, and like you say, Asha, it is, nurses have that holistic ability. And what I wanted to ask Nigel and the rest of the panel really is, what do you think the early career nurses can do within what is quite often our very limited circle of control to generally propel the professional and political agenda of nursing, and the areas of both nursing and society that we are particularly passionate about? Because quite often we're told to solely focus on developing our clinical skills rather than to be the leaders and the co-producers of change. So what would your advice be to those early career nurses that really have this innovative problem-solving idea mind frame?
Well, I think 2 things. One is the Nursing Now Challenge. That's precisely what it's for. It was, we were talking at the ICN conference in 2017 about setting up Nursing Now, and we thought we ought to do some big things around leadership for senior nurses. But actually, I got a bunch of people like you saying to me, actually, what about us? You know? And the response to it was the Nightingale Challenge, which is precisely about non-clinical development. And the idea is that we persuade employers that they should identify some of their nurses and midwives and set up a program that is around leadership, that is around understanding the system, around turning you into a professional who can be good at advocacy and communication, as well as your clinical skills. The clinical skills should be taken care of through your normal education. So that's what the Nightingale Challenge is, the Nursing Now Challenge is. So the first thing to do is get hold of your employer and persuade them that they should be part of this event.
Well, I'm very fortunate to do it through Sigma, so I have taken part in the Nightingale Challenge.
All right, okay.
I'm just speaking because I was a former chair of RCN students, and now I can see that on the webinar is one of the, she's the student representative on the Professional Nursing Committee, Kendall Moran, who is the co-chair of the RCN Newly Registered Nurses Network. And a lot of anecdotal feedback we do get is early career nurses are dissuaded away from the 4 pillars of nursing into solely focusing on clinical nursing and not developing as nurse researchers, educators, or into leadership and management.
Yeah, well, one of the nurses might give you a reply that's more detailed than I can, but let me just make let me make 2 other points here that are general. First thing is, some of this is about confidence. And you know, one of the things that I think the Nursing Now, I've been told this by people all over the world, one of the things the Nursing Now whole campaign has done is give people confidence to do things. Just give you that little bit of backing, and you know, I understand some of the sociology around this, if you like, or the anthropology around your role as nurses within the system and so on. But there is a bit about do it and ask for permission afterwards, if you know what I mean, that I think is really important. And the second thing is, this isn't about nurses versus the world. Let's also be clear about that. We're always very clear of saying every healthcare team essentially has got nurses at the heart. And if you enhance the role of nurses, you'll enhance the role of the entire healthcare team. And healthcare is a team exercise. People bring in their different skills at different points. Nurses are very often the continuity within it, and the human face, but actually you need the other guys and gals in there as well. So it's you know, so that there is a bit here, Craig, you're obviously a confident guy, of reaching out to the young professionals in other professions, you know, because you're not just a nurse, you're a young professional. So there is a bit there about how you're going to see with the doctors that are fed up with doing whatever it is, or the physios or whatever. Anyway, that's my comment. I don't know, Rachel, if you want to bring in a nurse to give him a more nurse reply.
Well, I am a nurse, of course.
Oh, you are? Yeah, of course.
So, and I think, but I think what I would reflect on actually, Nigel, is one of the comments you made there around what Nursing Now has given in terms of confidence, and that particularly actually outside of the UK, having, and I think you talked about the fact that Nursing Now in many ways took off first in Africa, in other countries. And actually, I think that focus on nursing in countries where nursing has a low status has been really important. And I know in some of the work that I do, one of my colleagues, Julia, who's on the call now with children's cancer nurses in low and middle income countries, then Nursing Now has been really important to them. You know, and sometimes people say, well, what does it do tangibly? And I think one of the things that it does is it makes them seen, and that's, you know, something that has built confidence of national nursing organisations away from the UK, which I think is actually a really important, very timely to bring in a question from Joan Myers, that I've seen in the chat. So Joan, over to you for your question.
Thank you. Good evening. Thank you, Trevor, for inviting me. It's good to hear you again, Lord Crisp. You've always been a phenomenal advocate for nurses, nursing and the NHS in the diaspora. And my question to you was, you mentioned that you were able to make a shift globally. You've got the chief nurse, the global chief nurse and everything like that. And as Rachel has just alluded to, making an impact in low resource or low income countries. Why do you think we've not been able to do that nationally or in this country? Because it appears to me as if the government doesn't appreciate or value nurses by offering us only a 1% pay rise. What do we need to do, or what do you think is the issue that needs to be dealt with?
Yeah, well, I mean, that was just crass, wasn't it? I mean, it was just bad politics, let alone anything else, it seemed to me. But I have to say, I could have got sucked into talking about nursing in the UK, and I've deliberately avoided doing it because
I could imagine.
you know, there's lots of you doing it. You know, there's lots of good people working in nursing in the UK. I don't know. I think the issue here is that we did talk to ministers. We did try and persuade them, but they just didn't quite get it. They haven't quite got that. Change is happening in the UK, but it's changing from below, is my sense. You know, it's people all around the country where we are getting more nurse practitioners, we are getting more specialist nurses, but at the same time, there've been cuts in community nursing, haven't there, over recent years, which seems to me completely barking as a way of going about things. So I think they just haven't got it at the national level. And I suppose where I try to concentrate here, I would spend a lot of time trying to find a few powerful advocates within the governing party, you know? And not necessarily the obvious ones. One of the lessons of nursing now, I think, for nurses, if I may put it like this, is you do need some non-nurses to be your allies. And this has been a campaign of nurses and their allies. And I know for some nurses they want nurses to be just by themselves. I know we've had that criticism. What's it got to do with people like me? But you know, and my answer is, well, I'm interested in health, and nurses are, you know, this extraordinarily valuable part of the health system. So I think there's all the tactics you need to do in a campaign here as well, Joan, which is, you know, as I say, find out who your allies are. Pick up the really strong points that you can take forward and just show them it works. And actually in the UK, you can show them it works. I mean, Rachel, you can show them it works. I mean, and what's interesting, and I bet this is true of other people like Rachel who are senior specialist nurses, is your biggest advocates are your specialist doctors, aren't they? You know, they all talk about the way in which, you know, you've got to have a oncology nurse, or you've got to have a breast care nurse, or whatever. Is that fair, Rachel?
I think historically that's fair. I'd like to think that we're getting stronger at advocating for ourselves
as well,
as a profession, and absolutely agree that healthcare is a team profession, and that you know, yes, absolutely, many of our colleagues, doctors and other health professionals are great advocates, but I think we also need to be very clear about our professional self-advocacy and the value of nursing. But
totally. I mean, you've got to be doing that, but don't do that at the exclusion of forgetting your allies. And they can open some doors. You can open some doors they can't open, and they can open some doors you can't open. I mean, it really works like that.
Yeah, absolutely. I'm going to move on to another question. In fact, Rod Thompson has two questions. So Rod, I'm going to ask you to choose just one of those questions.
Okay, thank you, Rachel, and thank you, Nigel. Nigel, at the same time as Nursing Now was being developed, Sigma, or as it's now known, but Sigma Theta Tau as it was then, was also developing its report on the global future of nursing. I'm interested to understand what synergy there's been between the work that you're doing, the work that Sigma was commissioned to do, and how on a global level we might use that intelligence and that impact to best effect to improve nursing across the entirety of the globe and not just in the more affluent countries? Yeah, no, great question. Can I say they're good friends, the people at Sigma, Theta, Tau, whatever, however many Greek letters it is, and we've worked with them on a whole range of things. And one of the things we did when we set up Nursing Now was to say we're not going to deal with nursing policy issues. There are plenty of you working out there on nursing policy issues, you know, education standards and methods and regulation and all that. How can we do that? But the things we will focus on is the impact on health, you know. So our territories are slightly different. Now, I think the report you're talking about, is it the Institute of Medicine report that was? The acronym for it was GOPFAN, but effectively the Sigma worked with each of the WHO areas across the globe. Oh, I know the one, yeah. Okay, yeah. So there is synergy with that, but there's been another probably bigger report, which was produced by the Institute of Medicine in the US 10 years ago, which was looking at global, it was really looking at American medicine. Thought it was global, rather like baseball and the World Series or whatever. Yes, yeah. And they've just produced their 10-year follow-up. And there's a lot of synergy between all of these things. You know, you're working across a wide frontier because let us say you're in any country in the world that you want to name, but Ghana or somewhere. Not only do you have to get investment into the numbers and get people paid decently, you've got to change the services, which is where we're most interested about, you know, nurse-led clinics and so on. But you've also got to get the regulation shifted and make sure the education's right. So this is a very broad front. And the really key thing is that people across that entire broad front need to be talking to each other, which is your point. When I launched Nursing Now Australia in 2019, they brought together 32 national Australian nursing groups for the launch. The first time those 32, I mean, there was rural ones and urban ones and small town ones, and they all call themselves national and so on. They've now reduced that a bit, but actually they need to talk together. And one of the things we say in our final report is that partly because we're not a threat to anyone because we're not going to exist after the end of May, you know. So I'm not trying to take anyone else's territory in any way. That we were quite good at convening people as a group, and it's really important that nurses will work across those barriers and work with each other, whether you're specialist nurses in hospitals, whether you're primary care nurses, whether you're public health nurses and so on. And I think that's the general point at the global level. And I think it's better than it was. ICN, Sigma work well together. The Institute of Medicine we got involved with and so on. So, you know, there's the trying to avoid competition, trying not to work on the same things is really important in that. But it's a big issue.
Thanks very much, and thanks for the question, Rod. And I just want to pause just to recognise that we've been joined by two people who I know weren't able to be here at the beginning. So first, our current president of the Royal College of Nursing, then Professor Anne-Marie Rafferty, who's here with us, and Josephine Ochiamba, former Deputy Secretary General of the Commonwealth. Just welcome to both of you, and if you have any questions for Lord Crisp, then do feel free to direct them towards me. And our next question is from one of my fellow members of the Professional Nursing Committee, so Professor Alison Leary. Alison, would you like to give your question?
Thanks, Rachel. I've just come from a seminar, actually, from some specialist nurses, a worldwide seminar in gastroenterology, where the nurses are still being asked to prove their worth. And we've actually developed many tools to help people do this. I can't believe there's still a need for it. And whether it's things like safe staffing or the value of specialist nursing, the focus seems to very much be, and quite understandably, an economic one of most hands for least money. And it's almost as if patient outcomes are a sort of subsidiary of that. They're not the focus of healthcare. what we can do to kind of change that narrative and influence in terms of focusing more on quality and safety as desirable outcomes rather than just delivery of task.
Yeah, absolutely vital point. I mean, there are 29 million nurses globally, so you know you've got examples of everything globally, haven't you? So, but you don't surprise me at all. I mean, I remember the I better not say which country, but the minister saying, you know, and of course all nurses should be women. He said this to a conference, a Nursing Now conference, which, you know, I don't think he realised why you know everyone groaned, but there we are. You know, yeah. so there's an awful lot of change, and we also need to be a little bit careful, even in situations like that, that we're not just exporting a British model of nursing or an American model of nursing. On the quality point, I mean, it's extremely valuable and well-made point. And I get a sense that things like COVID are shifting some of that. Actually, there's external factors that are making people think not just about numbers. I mean, after all, we've just thrown away, haven't we, a waiting list that was down below 1 million, and now it's over 4 million, I think, in England or whatever, and just set aside those targets, which were the activity and the numbers ones, and concentrated on a very straightforward outcome, which was dead or alive, in terms of how we're measuring what's happening in COVID. And I think there's a bigger appreciation. So I think there are factors that like that one can start to build on. I think there's evidence, and I know you are, from your reputation, a great person for providing evidence, Alison, and we do need to keep getting that out everywhere. And that's why I think the State of the World's Nursing can also be helpful around that. But again, I think there's something here about allies, because this isn't just the only profession that feels that. And I think you're extraordinarily powerful as, I'm not a health professional, my background's a philosopher, but the health professions together are extraordinarily powerful. And I think you need to find better ways of working at using that. And I think part of that is the young people, actually. I think Craig, if he's still here, and indeed is in the middle of my screen for some reason, Craig, that you know, people like you can be in some ways maybe even braver in a way, and certainly less deferential than I think people of my generation, not saying nurses of my generation, I'm saying people of my generation, can be about this, to sort of shift the agenda onto quality, and onto society, because it's how we live. It's not just the quality of the clinical outcome. It's you know, why have we got such awful housing so many places in this country? Why have we got jobs that don't have security? You know, these issues are health issues, and we need to be paying a lot of attention to them. Anyway, there's more to say on that, Alison. I'm sure you've got lots of ideas, but we've only got 2 minutes or something. I better hand back to Rachel.
And a few more minutes, so just a couple more questions. I know we're working you hard with questions, but this one is coming from a slightly different tack, I think, and importance. So Anna, I think you had a question about the health of nurses, rather than nurses' impact on health. So Anna, would you like to ask your question? We still got you here, Anna? Do you want to unmute to ask your question? Perhaps I'll ask it rather than waiting. So Anna asks, you know, how much Nursing Now looked into the health of nurses, and especially the impact of the pandemic on mental health, and therefore how health systems can support nurses better.
Yeah, let me go back to the point that there was an awful lot of stuff that we didn't do because there were 5, I think the staff with any big time was 5, there were 126 countries involved and so on. So so the way we worked with countries was being vision-led and purpose-led, not plan-led. So we didn't tell anyone what to do. But we said, if you buy into our vision and these few points, then what are you going to do in your country? What are your priorities? And in some countries, this was a priority. I can't think immediately where, but we had people doing priorities from Jamaica, which was about violence against women, was they decided was a really significant issue for them. And there will have been other countries that picked up the health of nurses themselves. There was a lot on mental health. During the pandemic, during the pandemic, once the pandemic was really here, we of course had to go virtual, and there were quite a lot of webinars of various sorts that were run nationally by Barbara Stilwell and her colleagues, which were about compassion and about you know, looking after yourself and so on. So there was quite a lot of that. But as we say in our report, nursing now isn't one story, it's a whole lot of different stories, and it's be different in different countries. But Anna's point is good, well made. This is if you're not looked after and you can't look after yourself, how do you look after other people is quite a big question, isn't it?
Absolutely, and I think particularly brought into focus by the pandemic and the last year of the experience of nurses. So I have one final question before handing over to Tim. So Danny Kelly, Danny, you've got a final question.
Thank you, Rachel, and thank you, Nigel, on behalf of everyone, really, for the work that you've done over the past 3 years. My question is about really where the power lies in nursing. And for me, I'm quite interested in the nurse in the boardroom, the executive level, you know, the decision-making forums where the budgets are carved up. And I just wondered if you had any focus on that aspect of nursing, because for me, that's the...
Yeah.
Sometimes there are research and we have lots of titles, not much power, perhaps.
Yeah, no, absolutely right. In fact, when I said we were purpose and vision led, there were about 4 or 5 things that we said in the top there, and it included nurses as leaders and nurses in decision making. And we did have a rough target, which actually we exceeded, of saying we wanted 75% of countries to have a chief nursing officer by the end of the campaign. That has happened, and some of that's been due to Nursing Now. You know, it's been explicitly due to Nursing Now. But having a chief nursing officer is a title, and if the chief nursing officer is only dealing with nursing policy and not, as you say, dealing with the money and dealing with the bigger set of issues, or the wider set of issues, nursing policy in itself is important, then you don't get that influence. There was another campaign you probably know about on nurses on boards, which we linked with, which is an American-based one, and which again basically says, and again in our final report we reiterate this, that where there are decisions are made, nurses should be part of it. It is very odd that we have the people who actually know how the thing works, which is basically what I remember when I was chief executive of the John Radcliffe. There were different groups of people I listened to in those days. One of them actually was the switchboard. Fantastic to know what was going on there. Another one was A&E, and thirdly was nurses generally. You know, you want to know what was going on in the middle of the night or whatever, then these were the sort of places. So why aren't these people who understand how the thing actually works part, not the entire of, but part of the executive team? In a real way and not in a sort of token sort of way. So I think this is a big issue. I think again it's shifted a bit. I think more countries do have chief nursing officers. Whether they've got the right job description and the right power, I don't know, but you know, but it's a generational thing. This will take a long time to shift, but it is moving in the right direction at the moment, I believe.
Thank you. And although I said that was the final question, I'm going to squeeze one more in from Josephine Ojiambo. So Josephine, you have the final question rather than us giving the last word to Danny.
Thank you very much, Rachel, and thanks for giving me this chance to speak, to share. Thank you, Lord Nigel, for a very interesting discussion. And of course, I want to acknowledge all the inputs into it. I have a question on technology and informatics. And I just wanted to ask your comment on the use of technology and informatics today in nursing practice. More and more, we've seen technology is really useful. There's some questions about whether it's going to take away the roles of others. Nursing, like any other healthcare profession, really relies on a one-on-one engagement. And questions are being asked about, well, better decision-making, but also the need for this interpersonal communication around nursing. What would be your comments on the use of technology and informatics? Thank you.
Well, technology is extraordinarily valuable. Digital health, there are two meanings of digital health. Only one is about technology, the other is about digits, you know, your fingers, hands-on. You know, healthcare is a human contact sport, if you see what I mean. I think that's part of what you're saying. And both are important. Now, sometimes technology gets overhyped, but I have seen examples in Africa where you really can reach people in ways that you couldn't do 5 years ago. So I think of midwives actually in Kenya is the one I'm particularly thinking of, where they are with portable ultrasound right out miles from anywhere, and with a tablet able to send the reading straight back to the hospital where it's read and sent straight back to them. So technology is enabling mothers to be, you know, provide some safer care for mothers to be. So there are some very clear examples where technology is really impressive, but it's technology enhancing the skills of the people. There will be cases where technology will replace people, but by and large, those will be jobs where you don't need people in principle, where we're probably not very satisfying jobs, and people will have more. In the ideal world, they'll have more of the richer or more rewarding jobs to do, the ones where they have to exercise judgment and professional skill and so on, as those midwives do in Ghana. So you've got a whole range of different areas where technology will make a huge impression, but we mustn't let technology companies and others suggest they've got the answer. You know, technology will be very helpful, but it's helping you. It's not replacing you, except in a few cases. You know, I mean, they can do as much of the administration as possible by technology, of course. Let's try and do that, and let's use barcodes. You know, on everything that you need to fill in forms for now. You know, let's use those sort of aspects of technology. But technology is a servant in the context. But it'll be very, very, you know, it's one of the reasons why I think nurses will be taking a much bigger lead in primary care, because there'll be far fewer things that you'll need to rely on another profession, because actually you will find the technology is enabling you, and then you can link in via technology to the centre of excellence or wherever it is you want for the full professional specialist professional support. Yeah. Again, a long question.
Thank you, and a really important one. Just before I go on, hand over to Tim, I'm going to crave your indulgence and the indulgence of the meeting for a few minutes, just to ask Anne-Marie Rafferty, our current president of the Royal College of Nursing, if she'd just like to make a quick comment before we come back to Tim. So, Anne-Marie.
Thank you very much, Rachel and Nigel. It's been fascinating. I'm sorry I was caught up at the Abbey beforehand and couldn't get here on time. But I mean, I've been a great admirer of nursing now from afar, and I just think the advocacy model and the sort of centrifugal force that you have generated on a global scale to empower nurses has been phenomenal. And I just hope we can kind of bottle it and produce it like a global version of Iron Brew. I think Rod will like that one. And so will Craig. Yes, Craig, definitely. That's what we need. more Iron Brew. And how it then, you know, is translated into, decanted, using that metaphor, into ICN, I think is going to be a really critical next stage. You've probably already discussed this, but that's what gives me personally great hope for ICN as well. Not that it needs my vote of hope, but I think the combined power of ICN's infrastructure and Nursing Now's advocacy is going to unleash a kind of, I hope, nuclear reaction of nursing power globally that we will see translated into some of the objectives in your vision and a number of the topics that we've discussed this evening. So more power to you, Elbert, and thank you for your leadership and, may I say, allyship too, being a key champion and ally of the nursing world. So I'm sure you're not going to be off the hook. We'll be calling at your door for the years to come, Nigel. So thank you so much.
Well, thank you, Anne-Marie.
Nursing Now and yourself.
Thank you.
Love the idea of a nuclear explosion powered by Iron Brew. So Tim, over to you for some closing remarks and a vote of thanks.
Thank you everybody, and again just to say congratulations to Anne-Marie Rafferty, who was our keynote speaker last year and is now a Dame, so that's really good, and it's good news for the nursing profession. So in terms of starting off, what I'd like to do is just mention the nurses and other health professionals that sadly have died over the last year, as a result of COVID, and I think we do need to honour their contribution and their legacy. So I suppose that in my closing remarks, we've heard a lot about public health, and I think given the changes that happened in 2013, where the significant changes and reform around public health, that's done an awful lot of damage across the whole area of medicine, nursing, and so on. And I think what COVID has done has really highlighted, brought to the forefront what public health can do when it's allowed to do that. And again, if you look at the visibility of public health, it's been much more visible. And certainly when I've been watching the TV around 6 o'clock or 5 o'clock, I've often seen a public health doctor or nurse, explaining what we need to do. So I think there'll be a lot more respect for public health, given their visibility. And it's not just been around the intensive care nurses who've been doing a wonderful job in the intensivists looking after dying patients. It's much more around public health. Moving on to the vaccination programme, and I'm being very parochial talking about the UK. If you look at the vaccination programme, it's been very successful. I've heard today that a third of the UK population have now been vaccinated with two vaccines. Another third have had their first vaccine. And if you look at who's been leading that, it's been nurses. They've often been the accountable officer responsible for leading, organising. And as we've seen today, people have not been able to be part of this meeting because they're vaccinating, which is great news. So in praise of nurses and midwives, and as it's International Nurses Day, I'd also like to acknowledge the other people that have been involved in the vaccination programme. Certainly, I've observed nurses, student nurses, healthcare assistants, midwives, physios, dietitians, dentists even, doctors, immunising. But within Manchester, we've also had airline pilots, cabin crew staff, and I was vaccinated by a driving instructor who was incredibly competent. So I think, again, nurses have worked in that very collaborative way of bringing everybody together, a bit like when people do in wartime. They've had the ability to, again, get the MDT to function. So I think it's a great opportunity for nursing, and for nursing to thrive. So I suppose just to say thank you now. Thank you, Nigel. Thank you, Rachel, because we're on first name terms now. Thank you for Tim McNally at National Liberal Club for organising the IT. Did a fantastic job this year, did a fantastic job last year. And again, more importantly, to Trevor, who's pulled together this event, as he always does, with good communication, with candour, with enthusiasm. So thank you, Trevor. And then just finally, to draw attention to next week's meeting, Baroness Kate Paraminter is going to be discussing climate change and biodiversity in 2021, a year of opportunity. So again, that starts at 6 o'clock and runs till 9 o'clock. So again, if you can sort of join that meeting, it would be really useful to do that. So thank you. So all I have to say now is thank you all very much for your contribution, for your questions. Have a good evening and stay safe.
Thank you very much, Tim. Thank you, Trevor, and thank you to everybody who's joined us this evening. Thank you.
Thank you, everybody.
Thank you,
Trevor.
Thanks, Trevor.
Thank you. Goodbye. Have a good evening.
Thank you. Have a good night, everyone.
Thanks, Trevor. Thanks, everyone. Hi, Elizabeth. It's good to see you. Hi, Colin. Hi, everyone. Hi and bye. Thank you. I think we're the only ones in the room. Oh, no, there's still quite a few people. Still. No one wants to leave this meeting. Is it finished?
It's finished, but there are still people here. It's always a good sign of a meeting if people don't want to go home.
Oh my goodness.
The trouble with virtual meetings, isn't it? Where normally people would hang about at the back having a chat. It's difficult to hang about at the back having a chat on Zoom.
Yeah, but it was a great meeting. I mean, my sister is a nurse, and I can see on her screen, her phone screen, Nurses Day. And I said to her, I'm in this meeting, you know, with Lord Crisp. And she said, well done, well done. And you know, I'm listening and I'm taking all these notes because I am thinking the nurses and the educators, they share so much in common in terms of how teachers or educators are treated. But, you know, one of the things Lord Crisp said, which, you know, I had a discussion with a professor friend of mine, colleague of mine. She's widely traveled, and she said one of the things she noticed in Eastern European countries is that teachers are highly respected, as well as nurses, but they hold positions of authority. They sit on executive boards, and you couldn't have someone being the Minister of Education if they had no educational background, which in the UK,
you can in the UK.
Possible. Yes. And so when Lord Crisp said that teachers, not teachers, but nurses need to be on that educational board because they know, they have firsthand experience of things, I thought, yes, we've been saying that about educators for such a long time. But it was very fascinating. I took a lot of notes. I might just write a paper on this. So yeah, even though, you know, it's health, I can still write a paper.
Rachel, you did a wonderful job of chairing. So thank you on behalf of everybody. Thank you very much.
No, thank you very much for inviting me, Trevor. And it was great to be here and great to see the insight. I think one of the things I didn't tell you that my uncle was Richard Wainwright, who was Liberal MP for Colne Valley. So I remember as a child coming to the National Liberal Club for tea.
You didn't come for this brew. I think Anne-Marie Rafferty mentioned this nice brew.
Iron brew.
I don't think they probably serve it in the National Liberal Club, although they should.
Well, they should. Rachel, it has the distinction of being the only soft drink that outsells Coca-Cola and Pepsi-Cola.
In Scotland.
In Scotland. It's the only place in the world that just outshines it.
Not to mention what it does to your teeth.
Well, what is Pepsi and Coca-Cola do?
No, well, Trevor, thank you for the opportunity. And
before we go, it's so nice to see Sue Warner with us this evening.
Yes, so nice to see Sue.
Nice to see you, Sue.
Yes, thank you. It's nice to see all of you.
Lovely. Rachel, can we log off now? Because no one wants to go, so you might as well log off and we'll follow on.
I can't end the meeting, but I will log off. So
thank you very much.
Thank you.
Bye-bye.